I'm Harriet Vanswell, Associate Professor of Medicine from McMaster University, and I'm so delighted to have Professor Javed Butler, Distinguished Professor of Medicine at the University of Mississippi Medical Center in Jackson, here with us as Principal Investigator of the EMPACT-MI trial. He is presenting his results at the late-breaking clinical trial session of ACC 2024, and we're here to chat about the trial and its results. Welcome, Javed.
Great to be here.
I wonder if you could tell our viewers about the hypothesis that you aimed to test with this EMPACT-MI trial.
Yeah, so, we have seen a lot of advances in the management of patients post-myocardial infarction, right? So the whole revascularization strategy, systems of care, quality metrics like door-to-balloon time, and then reducing the risk of recurrent MI, whether it is dual antiplatelet therapy, lipid therapy, and all of those things have really changed the landscape of how we treat myocardial infarction. But one feared complication of myocardial infarction is the risk of developing heart failure after myocardial infarction. And actually, the risk of developing heart failure, that's one of the worst prognostic factors post-MI. So the idea behind this study was to take a broad group of patients with myocardial infarction, STEMI, non-STEMI, those with or without diabetes, and test whether giving patients post-myocardial infarction early, we're talking about within the first 14 days, SGLT2 inhibitor, empagliflozin versus placebo on top of all the revascularization standard of care, whether it will reduce the risk of developing heart failure or all-cause mortality. So that was the hypothesis that we were testing.
Sure, and we've certainly had a broad evidence base to support the use of SGLT2 inhibitors in both the prevention and treatment of heart failure. So this adds to that body of work and also to the recent DAPA-MI trial, right?
Yeah, absolutely. So, in the DAPA-MI trial, we again learned that the cardiometabolic benefits with SGLT2 inhibitors that we saw in patients otherwise, ischemic heart disease, chronic kidney disease, diabetes, DAPA-MI showed those metabolic benefits. But the number of events were too few to focus on the cardiovascular outcome. So that was one of the reasons to focus on this trial as well.
Sure. So you sought to test the efficacy and the safety of empagliflozin compared with placebo in people who were either actively hospitalized or recently hospitalized for MI, and they had characteristics enriched for heart failure. Tell us about those inclusion and exclusion criteria of yours.
Yeah, certainly. But before I tell you the inclusion-exclusion criteria, you actually mentioned something which is really important, which we take for granted, and we really should not take it for granted. And that is that when we do these trials, we test for efficacy and safety. And safety is really important, right? I mean, first, do no harm. And the reason, so you can sort of ask me, like, why are you concerned about safety? Because we have tons of data in trials documenting safety of SGLT2 inhibitors. But here's the trick. How many trials do we have where you have a person with acute MI who's getting IV contrast, getting procedures, and getting a new onset initiation of RAS inhibitor, MRA, and SGLT2 inhibitor, who's also getting hypotensive, and all of that goes on with acute MI. So actually, safety was an important consideration in trial as well. And the safety that we have learned from other studies may or may not be applicable to the post-MI population. But coming back to your question, the eligibility criteria. So the eligibility criteria was, one, patients who already had history of heart failure were actually excluded from the study. So you were asked not to have a history of heart failure to begin with. But then you either had congestion requiring treatment, doesn't matter what the EF is, EF could be 60%, no problem. But if you had congestion or you had a new drop in ejection fraction to less than 45%, we know stunned myocardium, these acute drops in ejection fraction are prognostic factors as well. And then we sort of had a whole series of what we call enrichment factors. There were like 8, 9 of those. age over 65 or EF less than 35 or peripheral vascular disease or high PA pressures or diabetes, sort of all of these enrichment factors, and you just needed to qualify having one of those. So that was the patient population that we included in the study.
Tell us a little bit more about the study design. So this was a randomized controlled trial. What was the protocol like?
Yeah, so that actually becomes a little bit important when we discuss the results. So it was a pragmatic, sort of a streamlined trial. So, the cost of conducting clinical trials is a real problem right now. And a lot of the time, we don't answer important questions because the cost of doing clinical trials is very high. So we try to make it really practical and really easy on both the sites investigators as well as on the patients. So, for instance, the inclusion criteria were pretty much, if you have any of these things, you just come in. We don't have the sort of the long list of things, as I said, STEMI, non-STEMI, young, old, diabetes, no diabetes, sort of all comers. Second, we had really few face-to-face visits. So we basically had at the time of enrollment and then at 6 months, and everything was remote. So we didn't have people come back to us for 10 different times. The data collection was also streamlined, and sort of the data that we really needed to collect, but not sort of all the nitty-gritty details sometimes that we collect, that, as you know, we sort of never look at or publish, and then we question, why are we collecting all these data? So the data collection was very streamlined. And then also very important is that we did not have any central adjudication of the event. So we basically had adjudication at the site level. So we gave some education to the investigators, but we did not centrally adjudicate. Now, whenever you sort of go for pragmatism in the trial, you do exchange some things out, right, for pragmatism. So a couple of things. One is that our primary endpoint was all-cause mortality, not cardiovascular mortality, because we were not adjudicating the cause of death. And also, we all know that outpatient heart failure is a growing event. So a lot of the heart failure is diagnosed and treated in the outpatient setting. What the predominant data right now suggests is that the hospitalization, whether you do central adjudication or you look at the sites, the concordance is 90%, in that range. But the concordance in outpatient heart failure events for central adjudication versus what the site says is somewhere in the neighborhood of 50%. So it's not that accurate. So we only included hospitalized heart failure events in the primary endpoint, and we did not include outpatient events overall. So these were sort of the study design specific features.
Tell us about your sample size and baseline characteristics in both groups.
Yeah, so we enrolled about 6,500 patients and followed them for about 530 primary events. I think we ended up with 565, if I remember it correctly. So the rest of the characteristics for the patient population was pretty much as you might expect, a healthy mix of those with and without diabetes, with and without CKD, all the comorbidities that you might expect. There are only two things that I want to highlight. One is that as a clinical trialist community, we are trying, and I don't want to take away anything from the sponsors, the AROs, the CROs, the investigators, you and me, all of us are trying, but we are still not hitting the mark on enrollment of women and minorities. And I think more work needs to be done. In US, the minority enrollment is obviously higher in a global trial than the global enrollment. But there's always this unease that we don't hit our margin. I don't have the exact numbers on the top of my head, but that was an ongoing concern throughout the trial. The second thing that I would say is that if you look at real life registries and clinical trials, we saw that with the ARNI trial as well, is that the ratio of STEMI to non-STEMI is almost flipped. So in real world, there are about 3/4 are non-STEMIs, and these patients are at a higher risk of development of heart failure and have higher cardiometabolic comorbidities and potentially more chances of benefiting. STEMI patients, they come in, and if they're at a good center, they come in with a closed blood vessel, they get angioplasty right away. And, you cannot make, Scott Solomon has said this in multiple podiums, that you cannot make better. And these people have very good prognosis with this STEMI. And in the clinical trial, both ARNI trial and now in our trial, 3/4 of the patients were actually STEMI and not non-STEMI. So this is another peculiarity that I want to highlight.
Sure. Was the uptake of co-interventions the same in both groups? And what were, any hint at gaps in medical therapy that's evidence-based at baseline?
So one big gap that I would like to say that we are better than others, but that does not make us really that much better. So revascularization was done in 90% of the patient, RAS inhibitor, beta blocker, a statin use, aspirin use, all were sort of, 90%, north of 90% range. So pretty satisfied with all of that. MRA use post-MI still is a problem. So traditionally, post-MI trials have shown around 35-40%. We, I think, were about 47%. So we were more closer to 50%, but still some gap there.
Sure. And you compared empagliflozin 10 milligrams daily with a placebo. Now, you included patients who had established diabetes in this trial. So tell us about some of the considerations. There should be equipoise, and people who are randomized to placebo should get standard of care. So what were some of the debating points, and why did you choose to include diabetes?
Yeah. So one, patients with diabetes clearly are at a higher risk with all of these comorbidities. So whether you have CKD, whether you have heart failure, whether you have obesity, whatever. So if you have diabetes as a concomitant comorbidity, patients are at high risk, both for adverse clinical outcomes, but also for safety considerations and renal dysfunction and all that kind of stuff. So we really need data on these patients, but there is a little bit of a tension there, as you're alluding to. And that is that, boy, if you already have an indication, how can you randomize to placebo, right? So one, when this trial was designed, at that time, HFpEF patients, we did not have data with SGLT2 inhibitors. So those data were sort of brewing. HFrEF, we had data, but remember, we excluded patients with history of heart failure from the enrollment of the study to begin with. So the bottom line is that if you have patients with CKD or diabetes or heart failure for any reason that you want to give off-label treatment and you think that the patient is indicated, then I think the clinicians should do what they think is in the best interest of the patients. But all the CKD and EMPA-KIDNey and HFpEF and all of those data were sort of being developed and not there when the study was being designed in the initial phase of the study. What we were concerned about, a ton of off-label and open-label use, right? So that we were concerned. But so we tried to, massively increase the size of the study from what it was originally planned, just so that we can have a shorter follow-up and event rate so that we don't put patients at risk. So long story short, we only had open-label use of about 6%. And we just sort of finished the trial in time that HFpEF and CKD and all of these indications are now being ramped up in the clinical practice, did not affect the trial that much.
Sure. And while the trials in diabetes with cardiovascular risk factors or established coronary artery disease had preceded this trial, SGLT2 inhibitors are routinely withheld when patients are hospitalized with an acute illness. So perhaps that was another deciding factor in the inclusion of people with diabetes in this trial that tested the efficacy of the drug in an acute setting. Tell us about your primary results.
Yeah, but not only that, but also all the previous cardiovascular outcomes trials with SGLT2 inhibitors included patients with ischemic heart disease, but a remote history, not acute. So acute was actually systematically excluded from those trials. Okay, so the primary result. So the primary result was all-cause mortality and heart failure hospitalization. which is sort of a surrogate for development of new onset heart failure post-MI. So we did not meet our primary endpoint. There was a 10% relative risk reduction, p-value of 0.21, did not meet the primary endpoint. When we look at the components of the primary endpoint, there was no reduction in all-cause mortality, but there was a statistically significant, now nominally so, because we are not alpha protected anymore, but there was a 23% statistically significant reduction in heart failure hospitalization. So we dug into the results a little bit more, and we looked at all heart failure hospitalization, first and recurrent combined, and there we had a 33% relative risk reduction. So these are not only directionally the same, but even the magnitude of about 25 to 30% reduction in the heart failure hospitalization risk that we have seen in all other SGLT2 inhibitor trials, irrespective of the disease state. But we have a very interesting twist in the results. But let me ask you the question about the primary endpoint before I go to the interesting twist.
Right, and I think that your selection of primary endpoint was really the most relevant, but there's a tension because a lot of our therapies are designed for cardiovascular risk, right? And so when we pivot from cardiovascular deaths to all-cause death, there's a risk in that you're testing the most relevant endpoint to a patient, but you might not establish or demonstrate efficacy in that primary endpoint. And the same goes for all-cause hospitalization. But I think it's relevant because in people at the higher end of the EF spectrum, non-cardiovascular, non-heart failure causes are more common than cardiovascular ones as reasons for hospitalization. So kudos to you for selecting relevant endpoints, and also in your key secondary endpoints to explore the cardiovascular and heart failure specific endpoints. Did you see any change in cardiovascular death? Or did you look at cardiovascular death? I don't have your slides. I haven't reviewed them.
Yeah, no. So first, let me be very sort of transparent and say that as clinical trialists, when you're looking at these data day in and day out, maybe you start seeing things. So the neutral world will absorb the results. I can just give you sort of my perspective, having looked at these data in incredible detail for several weeks now. So first. We, as I said, we did not adjudicate, but yes, we let the sites tell us whether they think it's a cardiovascular or non-cardiovascular death. But there are a few things that are pretty peculiar here. So one, obviously, the earlier part of the trial was in the COVID era, not the later part, but that we all know had affected the heart failure hospitalization pattern, and we were started to get concerned that maybe there's more outpatient heart failure. That was one concern. Two of our highest enrolling region were unfortunately in global wars. So Israel was a big participant in the trial, and so was both Russia and Ukraine. So we had to suspend some of the things there. So that was another twist in the trial. Okay. And then the third thing was this all cause and no adjudication. Having said all that, you don't expect early mortality post-MI to be affected with SGLT2 inhibitors, right? So early post-MI, ventricular ruptures and stent closures and all that kind of stuff that happens in the very early phases of post-MI, that you cannot expect to change with SGLT2 inhibitor. The question to ask is, well, but heart failure is a really good marker for mortality. So if you're reducing 33% reduction in the risk of heart failure development, why would that not translate into all cardiovascular mortality benefit, right? And that's the problem, is that the average duration of a study was about 1.5 years. The average time to development of heart failure was about 6 months. So we had really a little shy of a 1-year follow-up, and we just did not have the long follow-up. So that of all the deaths that occurred in the trial, post-heart failure development, there were only about 20% deaths, right? So we just did not have the power. At least that's the way I'm sort of looking at the results. But I still have that exciting twist.
Go right ahead and tell us your exciting twist.
So the exciting twist is that, as I said, we had sort of streamlined trial. So we sort of define what are the safety things that we are specifically interested in, or the safety of, special interest, like renal was obviously special interest and all that kind of stuff. So one of the things was cardiac failure as a SAE, not as an outcome, as a serious adverse event, all heart failure event. So while we did not adjudicate, we did not have the in the primary endpoint, we did collect data on the outpatient heart failure events as part of the SAE collection. So now it gets pretty interesting that if you look at both in and outpatient events, and again, to be pretty explicit, this is not part of the primary endpoint, this is exploratory, this is part of the SAE. But we actually do have data on what the sites thought was an outpatient heart failure event. And if we put all that together, the magnitude of benefit goes from 23% relative risk reduction and 33% relative risk reduction for time to first and total heart failure events to 37% relative risk reduction. So it gets a little bit stronger. That could be expected. But now, if you look at all heart failure and all-cause mortality, even that is statistically significant. And then we used a surrogate marker of outpatient requirement for heart failure medication. So you left the hospital without the heart failure medication, but it was subsequently started as a surrogate. And substantially statistically significant lower risk of being started on a RAS inhibitor, on a beta blocker, on a MRA, and a diuretic. So I think that, yes, we did not hit our primary endpoint, but all the data that was part of the endpoints and then all of these exploratory data makes me believe that the heart failure results are real and not a chance finding.
And your event rates, were they as expected for the primary analysis?
No, so the event rates were lower, right? So
again,
maybe I can just pull up the presentation and just make sure that I give you the real event rates and not the made-up event rate. So the event rate in the placebo arm for the primary endpoint was 9.1 per 100 person year, and in EMPA was 8.2. If you look at mortality, in the placebo arm, it was 5.5%, and time to first heart failure hospitalization about 4.7%. And all of that sort of tells me that this is a reflection of 3/4 STEMI that are just coming in and getting revascularized right away. This is not either the patient mix or the event rate we see in real life. The event rates in real life are much higher.
Sure, so well-managed patient population, and another factor perhaps in why you were unable to demonstrate a significant reduction in that primary endpoint. Thank you so much for being here this morning and for leading this important work and for sharing your results with us, Javed.
Always a pleasure to talk to you, Harriet.